Hello, everyone. My name is Jennifer Pelagi, and I am a board member of the Intermountain chapter of APIC, which is the Association for Professionals in Infection Control and Epidemiology. I am also a quality improvement consultant with Paulus Health, the Quality Improvement Organization, or the QIO, for Idaho and Washington. These two organizations are partners in delivering this very popular HAI Prevention Learning Network webinar series. We have planned this series to bring you infection prevention information and expertise that addresses issues you face every day in your patient care world. If you have a subject that you'd like to see presented in the future, please take some time to pass along those ideas to us. Our emails are provided on the event flyers and on the slide deck handout at the very end. Let me take just a few moments to briefly address some housekeeping items. I thank you all for joining us today. We have over 200 registrants and many additional listeners sharing those lines. And because of this reason, we will keep all the lines muted during the presentation, but we do invite you to submit questions or comments in the chat section of your WebEx screen down on the right-hand side. We will also have a question and answer period at the end of the talk. I want to extend a special thank you to Acumetra Health, Oregon's QIO, and also to neighboring APIC chapters, state HAI coordinators, and hospital associations in helping us extend this invitation to healthcare providers across many settings in Idaho, Oregon, and Washington. RN continuing education credits are available for one contact hour as approved by the California Board of Registered Nursing. Those interested in receiving credit, please complete the sign-in sheet that was emailed with your handouts and be sure to include your email address and nursing license number. If you are not an RN but would like a participation certificate, please let us know on the sign-in sheet. Completed sign-in sheets can be emailed or faxed to me. A CEU certificate will then be emailed to you in about a month. Handouts were sent to registrants ahead of time and will also be made available on the Intermountain APIC website, which is apicintermountain.com. Also, you will be offered a brief online survey at the close of the presentation. Please complete it. It only takes a few moments, and we can continue to improve our offerings and format with your feedback. Now let's focus on today's topic, engaging patients in hand hygiene. We are excited and honored to have with us today Timothy Landers, who was the guest editor and study author in the May 2012 AJIC, or the American Journal of Infection Control, supplement, which focused on emerging trends in hand hygiene. Tim, I'm going to hand it over to you, and you have our attention.
Great. Thank you very much. Hello from Columbus, Ohio. Very excited to be with you all and talk about a topic that doesn't get as much attention probably as it deserves, and something that increasing attention has been paid to the role that patients play in preventing healthcare-associated infections through hand hygiene. So that's the goal of the next hour. Specifically, I'd like to review the evidence for the role that patients' hands play in the transmission of infection and probably in increasing their own risk of infection, and then describe current efforts to include patients in hand hygiene programs, and then to think about different considerations for implementing patient hand hygiene programs. So that's kind of what I wanted to cover. And I did have wanted to get some feedback from you all. Different facilities are doing patient-centered hand hygiene programs in different ways. And so I wanted to find out from you if your hospital or institution has a program in place to increase patient engagement in infection control and prevention. So if we could pull up the polling window. Does your hospital or institution, and maybe as a little hint here, the Joint Commission has recently revised their standards to require that hospitals include patients in infection prevention programs, and that patients and visitors and families be provided with education around infection prevention and what that means, particularly around hand hygiene. So I don't have the results right in front of me, but as the computer calculates, we've engaged patients in different ways in infection control and prevention activities. And so what I'd like to talk today about is hand hygiene and patient engagement and hygiene. So it looks like 42% of people say that their hospital does have include patient engagement in some kind of infection control program, piece of your infection control program. So I'd like to ask specifically, does your institution or hospital have programs in place to engage patients in hand hygiene? So whatever form you think that might take, does your hospital currently do that? We know that there are different ways to engage patients. And we'll talk historically or what's been written and published about, which is including patients as monitors or auditors of healthcare worker hand hygiene compliance, asking their physicians and nurses and other healthcare providers if they did wash their hands and expecting that as part of their basic level of care. So specifically, engaging patients in hand hygiene, what I'd like to talk about is how we can encourage patients to perform hand hygiene themselves and talk about some of the implications of those kinds of programs. So it looks like it's about a third of you answered that yes, you have engaged patients in hand hygiene initiatives. And so I have a little bit of time towards the end where I wanted to find out the kinds of things that you all are doing in terms of patient-centered hand hygiene. In our recent edition of American Journal of Infection Control, we looked at patient-centered hand hygiene, and Drs. Boyce, Larson, and Pate were kind enough to write a foreword to that supplement, and they reviewed the evidence that patients can and do carry pathogens on their hands, and these become part of their resident or transient flora, and that these can go on to cause healthcare-associated infections. And so, as a place to start, I would just say that we were thrilled to have these three internationally known experts kind of comment on our patient-centered hand hygiene article as well as on a point-of-care article. And then along with that, we had an article that looked at multimodal strategies and including feedback and monitoring as part of this overall strategy. But as you know, these are three, I guess you could call them prophets of hand hygiene, and we were just thrilled that they were willing to write the foreword for our AJIC supplement. So our first objective is to look at the ways that patients' hands could be involved in the transmission of HAIs. And I want to talk a little bit about our natural ecology. I think this will be a review for most of us, but just to remind ourselves where we live, what we live in, and then talk about the role of environmental contamination and direct transmission of infections from patients to healthcare workers or from healthcare workers to patients, and then talk about just a couple of examples of patient-to-patient transmission, and then talk a little bit about endogenous versus exogenous sources of infection. In other words, where these bacteria, where these pathogens come from. So I was walking through a bookstore a couple of weeks ago and saw the recent edition of Scientific American, and this is enough to literally make your skin crawl, but it talked about our inner ecosystem and that we live in a complex microbiologic environment. And the point of this article was that some of these relationships between the bacteria that we harbor in our mucous membranes and skin and in our gut are actually good for us and good for the bacteria because they have a place to live. So in that way, there's a symbiotic relationship. Of course, sometimes these relationships can become parasitic when a bacteria starts to break down human tissue to try to release the nutrients that are stored in that tissue, and that becomes a parasitic relationship. And sometimes the organisms just kind of coexist. But this article was looking at the number of bacteria, and most of us have probably heard the estimate that we are outnumbered in our bodies, 10 to 1. There are 10 bacteria for every 1 human cell. And if you look at the genetics of our microbiome, the microbiologic environment in which we live, our genetic material is vastly outnumbered by the genetic material of our commensal organisms, the organisms that live in and with us. So I think it's probably fair to say that we live in the ecology of bacteria instead of bacteria living in us. Clearly, they're outnumbered. We are outnumbered by a wide variety of organisms, some of which can be pathogenic when they're introduced into a normally sterile body site, others of which have benefits to human health, and that can be by reducing the likelihood that a true pathogen is going to be able to invade our body, or by helping to release nutrients from foodstuffs that we eat. So in terms of our overall global ecology, we are vastly outnumbered by the number of bacteria, and they have an extremely short generation time. So 20 to 60 minutes, most of these bacteria will replicate. So literally by the time we're done with this conference call, the bacteria that have been living in our gut can be as smart as our great-grandchildren will be. So if you think about that, just how, as my colleague here, Kurt Stevenson, from the College of Medicine at Ohio State says, imagine how smart we would be if we grew up every 20 minutes. But they've also been around a lot longer in terms of the quantity of bacteria. We are clearly outnumbered. So I think oftentimes we have this idea that we live in a somewhat sterile environment, and that's simply not true. We are complex living organisms in a very rich microbiologic ecology. So the analogy that I think is probably more apt is Pigpen and the Snoopy cartoon character, where he kind of walks around and trails this cloud of dust and microbiologic material, germs and bacteria, and that as we interface with each other and with our environment, that we're passing these bacteria back and forth. It's just part of what we do and part of who we are. So that's just a little bit about our natural ecology. We live in a very complex microbiologic environment and share our bacteria with others that we interact with and with the environment quite readily. And I know that you all are acutely aware of the role that the environment can play in transmission of healthcare-associated infections. And this became clear for me when I was a graduate student and looked at doing some surface contamination for different objects, simulated objects. This was an old computer keyboard, a couple of other touch and non-touch surfaces that I put in the fume hood and then sprayed them down with Staph aureus, and there was a big sign on it reminding the other grad students not to go near or touch these contaminated surfaces. And so we left it there for 72 hours, and sure enough, we were able to recover lots and lots of Staph aureus from all of these different types of surfaces. So we know that the environment plays an important role in transmission of these pathogens. And of course, we interact with this environment in lots of different ways. And again, I'm sure that you all have stories similar to this one. This is one of our lab techs who was having a very busy morning and decided that the donut looked good and left the donut on the counter, but with this nice microbiologic guard here of this paper towel. But the point is that we interact with the environment. Even if we're careful about how we interact, we still interact with lots of different surfaces and with the environment in lots of different ways. So this lab tech was a little bit embarrassed when I asked about the donut, but I'm sure that you all have similar stories. But clearly the healthcare environment plays an important role in transmission of these pathogens. So we also know that there can be transmission directly from healthcare workers to patients, or from patients to healthcare workers, and from patients to other patients. And we think that the risks of transmission for patients as an index case might actually be higher than the risk presented by an index case that's a healthcare worker. So one example of this kind of thinking was a norovirus outbreak, and there were just over 4 times as many cases that were identified in a norovirus outbreak that were linked to patient transmission than were linked to healthcare worker transmission. And I think we all would like to think that part of that has to do with our efforts at hand hygiene and our knowledge of disease transmission, but we also know that patients travel throughout our healthcare facilities, that they may be actively shedding, and that they may not have the same attention to their own hand hygiene, cough etiquette, and other ways that these pathogens can be transmitted. And speaking to an audience of expert infection preventionists, I'm sure that you all have lots of examples of recent outbreaks that you've helped investigate where patients have been identified as the primary means of transmitting these infections. And despite all this, we haven't really included patients in hand hygiene programs. We know that patients are very commonly colonized. 6 times as many hospitalized adults were colonized in one study compared to non-hospitalized adults. Coliform contamination seems to be higher in certain types of units than in other types of units, and you can think about all of the factors that relate to risk factors for colonization or contamination on patients' hands. And going over these slides, actually with my 2 teenage sons, and they said, well, what is coliform contamination? So I started to talk about this ecology of our gut bacteria, and that fecal coliforms are a marker for transmission, and so those are poop germs. And we know that patients can be contaminated or colonized with coliforms quite commonly. So there are a couple of kind of key marker organisms that can be used to identify transmission or colonization among patients. And these are just 5 that have been widely studied, and that's MRSA on the hands of patients, the presence of C. diff spores, which presents different kinds of challenges, because we know that alcohol-based hand rubs are not always effective against C. diff spores. The fecal coliforms are commonly found. Acinetobacter are a very important pathogen, and vancomycin-resistant enterococci are also found. And there was some data published recently here in Ohio that about 40% of hospitalized patients after 48 hours were colonized with one of these 5 classes of bacteria. So if we get back to Snoopy here and think about Linus here interacting with the environment, also interacting with other people and with pet dogs. And we've actually had a study going on here at Ohio State looking at the risk for bacterial transmission for Staph aureus between pet owners and their pet dogs. And we know that people interact with their pet dogs in lots of different ways that they might not interact with other people, even their spouses, so that pet dogs can jump up on people's laps and lick people's faces and do all kinds of things that would not be deemed socially appropriate in our society. And also, in this cartoon is he's sucking his thumb, and so this raises the specter of auto-inoculation, or taking organisms that have been introduced into your microbiome and then introducing it into a sterile body site, resulting in a healthcare-associated infection. So some good examples in this one cartoon of potential risk factors for transmission. And so those are our normal ecology, which is heavily contaminated, and environmental transmission. So I hope that this review of our human ecology hasn't caused you too much stress or anxiety. Maybe the donut picture raised your blood pressure a little bit. I know it raised mine, for sure. But we do have some things that we can do to try to prevent the complications of patients becoming colonized or contaminated with these different pathogens. So I do teach in the graduate program here at Ohio State, and one of the questions that I get all the time is this going to be on the test? So this is not going to be on the test, but just wanted to make sure that we reviewed some of the ways that patients' hands could be involved in the transmission of infection, and that's transmission through the environment, direct spread to other patients, transferring pathogens to healthcare workers' hands, and also this idea of endogenous organisms, or auto-inoculation, becoming infected with organisms that originate from your own flora or from your own contaminants on your own skin. So other people have looked at the paradigm of patient-centered hand hygiene, and McGuckin has been a big advocate for including patients in hand hygiene compliance programs. These have historically focused on healthcare worker hand compliance. And so these are things putting tents or buttons saying that it's okay to ask your healthcare worker if they performed hand hygiene, the Clean Your Hands program, or the Partners in Your Care program, which started in Pennsylvania. All of these include patients as monitors or encouraging healthcare workers to wash their hands. And those programs have been somewhat effective, and we all struggle with trying to improve healthcare worker hand hygiene compliance in our facilities. But this seems to be one valid tool that can be used. And I apologize about this slide. Actually, I have two versions, neither of which are readable. So just to walk you through this model of patient-centered care. And the idea here is that we're empowering patients to really become partners and accept responsibility for their outcomes. And this requires a change in how we as healthcare workers think about providing care for patients. That we become more coaches and advocates for our patient as they become involved in this process. And it's also it's a bit of a paradigm shift for us to look at patients really being engaged in their care and sharing their responsibility. So Longton here in this model advocates for changing kind of healthcare worker perceptions, attitudes, and beliefs about patient-centered care. But on this side of the equation, it also requires some changes from patients, that they come to view themselves and accept responsibility for their outcomes, that they become engaged, be much less passive in their care, that they become knowledgeable about their conditions, and that we expect to be included in these kinds of outcomes. So if I'd just like to take a quick poll, if I can, maybe just through the chat. If you could just post in how familiar are you with this idea of patient engagement? Is it something that you've used as a model for your facility? Is it something that is new and coming up, or is it something that is kind of not yet accepted? So if you, in the bottom right-hand corner of the chat, I'd like to hear just this idea of patient-centered care, how relevant is it to your facility and to the culture in which you practice? Great. So it looks like lots of people are saying that they're familiar with the concept, and it seems to be something that's up and coming, or hopefully it will be, encouraging patients to get engaged in their care. And so, we've looked at this in terms of hand hygiene as a way to encourage patients to kind of monitor their safety. And interesting perspective from the pediatric hospital, right, that parents oftentimes are very involved in the care of their children. But it does take a shift for us then to be looking at engaging, expecting that patients will be outspoken advocates of safe care. So thank you for that feedback. That's very helpful. Clearly, it is an up-and-coming area, and frankly, from the perspective of a nurse educator, it's something that we need to do a better job of educating and training our students about how we can encourage and expect patients to be involved in their care. So the studies on patient hand hygiene programs to date, some of the somewhat discouraging evidence that does exist is that while most nurses and certainly or hopefully 100% of infection preventionists recognize the critical role that hand hygiene plays in preventing infections, the studies that have been done show that about half of episodes of patients using the bedpan or commode, bedside commode or toilet are offered an opportunity for hand hygiene after using the commode or toilet. Nurses, we tend to overestimate the number of times that we're offering hand hygiene opportunities to patients. So we still recognize that we have a long way to go, but we just tend to overestimate how often our patients are able to clean their hands. So I think it's fair to say that most published programs on patient-centered hand hygiene do what what has come up in the chat and the traditional approach as patients monitoring healthcare worker hand hygiene compliance. We do know that including patients as monitors or auditors of healthcare worker hand hygiene compliance is effective somewhat at increasing compliance by healthcare workers, and all of the programs that we mentioned earlier are effective in improving healthcare worker hand hygiene compliance. And also the Joint Commission standards now, which require patient education, patient and visitor education about infection control within the facility. So those are kind of the historical efforts to include patients in hand hygiene activities. And so now what I'd like to propose that we work on together is what we consider to be the next big step in infection prevention and in this whole field of patient-centered care, and that is a patient hand hygiene program. So what we're trying to say here is that as infection preventionists, clearly our focus is on preventing the spread of these healthcare-associated pathogens, preventing infections, but also these kinds of programs that are targeted at directly involving patients in their own hand hygiene is a hook that we can use to get patients engaged in their health outcomes and in their overall safety of care in this new model of patient-centered care. So if we think about the implications of a patient being more aware of their own hand hygiene practices, that has a huge potential to carry over into how they manage their diabetes, their diet, their exercise, their medication compliance. So it's while it is an important end in itself, it's also a means to get patients more engaged in their care. So in a commentary here, I was calling for the development of evidence-based guidelines that really are directed at the most important time for transmission of these pathogens, and that are based on the evidence of what is most tolerated and what is most effective in hand hygiene programs. So this is the work for us to do in the next couple of minutes, if you don't mind. And that is, I'd like to just kind of ask you to work through with me what the ideal components of a patient hand hygiene protocol might be. And to look at maybe 5 different areas for development of a patient hand hygiene protocol at your facility. And so this could relate to the timing of patient hand hygiene, the technique, how patients perform hand hygiene, and there are some important considerations for patients. To think a little bit about what the product formulation might need to be most effective, and then how we could provide effective education of patients, visitors, and staff around patient hand hygiene. And I want to just kind of finish with this idea of the multimodal strategy and how a patient-centered hand hygiene protocol really needs to be part of an overall strategy of infection prevention and of hand hygiene compliance at your facility. So this idea of best practice is, based on the evidence that we have available. And so we know the highest level of evidence, of course, are double-blinded, randomized control trials, and those definitely provide solid information for us to make evidence-based practice recommendations. But we also have expert opinion and case reports and kind of consensus. And so I think that those are levels of evidence that we often don't give as much credibility to as we might to inform our practice. So this is the first of 5 questions that I wanted to ask you about implementing a patient hand hygiene protocol where we ask patients to perform their own hand hygiene. How concerned are you about the cost of such a program? So we'll bring up the polling window and give you just a few seconds to answer. Is this something that concerns you? Or is it something that does not concern you at all? Or are you just somewhat concerned? Some of the costs of these programs might be the expense of locating delivery devices where they're going to be accessible by patients. The additional cost might be more expensive product formulations. Another cost to consider is shrinkage, which is a nice way of saying that it gets lost or stolen. And we know that sometimes that does happen when people are in and out of emergency rooms and people are not feeling well. So how the cost is something that we need to consider. So it looks like about 49, so around about half of people were concerned, somewhat concerned with the cost of such a program. And this is something that definitely needs to be addressed as we look at developing patient hand hygiene protocols. So in your practice in your facility, how concerned are you about patient ingestion of alcohol-based hand sanitizers? Is this something that's very concerning, somewhat concerning, or does it not really concern you at all? So I'll give you about 15 seconds here. We know that in some patient settings, in mental health settings, in prison units, that there are case reports of patients who attempt to get drunker, attempt to get intoxicated through the ingestion of quantities of alcohol-based hand rub, and is that something that concerns you from what you've seen or heard about? I can barely wait here, so there might be some solutions that we can develop to kind of mitigate the risk of these concerns about patient ingestion. So let's see here. Jennifer, is everybody able to see the results of the polling?
Yes, they are.
Okay.
Should be popping up onto their screen as well.
Great. So about a third of you are not concerned. I'm going to take the 32% who didn't answer as saying, well, it's not necessarily a primary issue for us. So how concerned are you about theft or shrinkage of alcohol-based hand sanitizers at your facility? This obviously increases the cost and can be associated with, it's basically just a plain loss for the institution. Without a benefit. So is this something that you think needs to be addressed? And there might be some solutions that we could talk about for addressing theft or shrinkage of alcohol-based hand sanitizer around how those products are stored, delivered, how they're dispensed, and the quantity that's available. So let's see here. So I do not have that. Oh, there it is. Okay. So the results here. So it looks like about a third of people, again, were not very concerned about theft or shrinkage, and in some places it's considered a cost of doing business. And again, we can talk about some strategies to mitigate that. How about environmental safety issues of alcohol-based hand sanitizers? Is this something that's very concerning, somewhat concerning, not concerning at all? We know that these are alcohol-based products and that there is the potential that there could be a fire hazard, that there are limitations in smoke compartments from the National Fire Protection Code, and that this is something that some facilities have to consider in a serious way. But in your facility, how important are these kinds of issues about environmental safety, flammability, those kinds of hazards? Right, so the computer is thinking as fast as it can here. All right, so just 4% of you are very concerned about the environmental concerns. But if you're at a facility where the environmental folks raise it as a concern, then that's something that you need to that we would need to consider in designing a patient hand hygiene protocol. And then lastly, we can make this one quick. How concerned are you about the development of antibiotic resistance in developing a hand hygiene protocol? And so primarily the use of alcohol-based hand sanitizers. And I think we probably could end polling a little bit early here because I think hopefully most of us know that hand hygiene programs play a critical role in preventing the spread of all infection, but particularly antibiotic-resistant infections. And we wouldn't expect that the use of alcohol-based hand sanitizers or washing with most soap and water protocols really would be associated with the development of too much antibiotic resistance. So some of you are concerned with that, not many. Right. So we would expect, though, that those concerns could be addressed with the development of a protocol that emphasizes the use of alcohol-based hand sanitizers and, when appropriate, hand washing with soap and water. So some of the things that I've been thinking about for development of the patient hand hygiene protocol. The first one is the timing when patients should be washing their hands. And there are some recommendations from Health Canada, and the Joint Commission has some suggestions. This graph, we're all familiar with the WHO 5 moments, and this was based on a consensus panel's recommendation and study of the timing and routes of transmission. So this, the 5 moments are directed at healthcare workers and when healthcare workers should be performing hand hygiene around patient care activities. And we have not yet developed the same kind of evidence-based recommendations for when patients should be performing their hand hygiene. I know my mom said after you wash your bathroom, after you use the bathroom, you always have to wash your hands. If your hands are dirty, you always have to wash your hands. And I don't think I dared to question where the evidence was for those recommendations. We just think it makes common sense. And in our group, this is in the supplement, we had a list of proposed times for when patients should be performing hand hygiene. After toileting, we're all used to doing in and out monitoring of hand hygiene, and we suggested that when patients leave the room is a good time as they're passing dispensers that they perform hand hygiene and upon returning to the room. And again, just thinking about if you're leaving the room to go to CAT scan or to the cath lab or for another procedure that you're likely to be out and about touching lots of other surfaces that you could either contaminate or could be contaminated. We also propose that patient hand hygiene be recommended before eating, drinking, or taking medicine, before invasive procedures, after coughing or sneezing, even with good cough etiquette, and then before and after contact with visitors. And this is one that contact with visitors is something I think we need to think through how we recommend it with, how we promote it with patients, that whether we're protecting the visitors or we're protecting the patients from the pathogens that visitors might bring in. So I have been trying to push for this little saying, and I just wanted to get your feedback on this quote. Patient hand hygiene after pees, wheeze, please, leaves, or sneeze, with the idea that this might be something that we could use as a moniker for when patients should be performing hand hygiene after they urinate or use the toilet, after they pee, after they wheeze, after they say please. So after they get something or give something, so tossing something back and forth, after they leave the room or after they cough or sneeze. So I'd be very interested in whether you thought this could be a useful kind of patient education moniker. I've gotten some feedback that it seems to almost trivialize the importance of hand hygiene, particularly as a robust method of preventing infection. So if it offends you, I'd love to hear that. If you think, yeah, this is something that we could definitely adopt, or something similar we could use as a recommendation for the timing of patient hand hygiene. So I appreciate the feedback in the chat box. And so the concern here is if we're looking at engaging patients in hand hygiene, we need to have recommendations that are based on the evidence about the timing when are infections likely to be acquired or transmitted, when are patients likely to inoculate themselves. And so the point is that we need recommendations that are developed in a very, very rigorous manner, similar to the WHO 5 moments, but that are really targeted at the highest risk moments, particularly for patients. So I think after today, I may not use that anymore, because if we want to engage patients as partners, real partners in their care, and facilitate patient patient-centered care. We don't want to be using childish or, kind of trivial monikers. We want them to recognize how serious it is. So I appreciate that feedback. And if you wouldn't mind, I think I get a sense here that it's not maybe the most useful thing, but so I'm going to just move on and just say that what we need to be thinking about is what really are the evidence-based practice recommendations for when patients should be performing hand hygiene. And a second thing to consider is the technique for patients performing hand hygiene. And we have good recommendations for the use of alcohol-based hand sanitizers by healthcare workers, when they should be used, how long they should be using alcohol-based hand sanitizers, or washing their hands, depending on the indication and the timing. And I would say that we have not yet developed the techniques that are most accessible and are most likely to be adopted by patients. So part of this goes to the next key consideration, in addition to timing and technique, which is product formulation, and that there are lots of different alcohol-based hand rubs or hand sanitizer solutions that are out there. Formulations include gels or foams, and it may be that in developing a patient hand hygiene protocol, that foams might be preferable because they're less likely to pose the danger of ingestion. The amount, unless the bottle is open and you take a swig out of the bottle. But it might be that different products might be better tolerated and accepted by different patients. The idea of having wipes nearby, particularly around mealtimes, might be a strategy that could be very effective for patients. So this is something that people are not unfamiliar with, and that it might be a product that they just prefer to use, regardless of the efficacy claims about which is kind of the better, more effective product, but which is also more likely to be tolerated. So we have to address patient preference, patient acceptance, when we're looking at the product formulations that are developed for patient-centered hand hygiene protocols. And most of the products and solutions that have been developed for hand hygiene currently are developed for healthcare workers and their preferences around a very high-use situation. So by expert users or workers who are on their way to becoming expert in hand hygiene, that with lots of indications over the course of an hour, over the course of a shift, that the product formulations are really targeted toward that market. And it might be that patients have different requirements in terms of product formulation, and that we need to consider those in development of these protocols. So let's see. Similarly, we want to be looking at how dispensers are placed and what the most effective location for patient hand hygiene dispensers is, and that needs to be part of what we look at in terms of our point of care strategies, where the dispensers are located and where they're most likely to be used. So I wanted to finish up here with this idea of a multimodal strategy. And I know that you all are familiar with multimodal strategies in infection prevention bundles, and that it probably makes the most sense to think about patient hand hygiene protocols as part of a multimodal bundle, if you will, for an overall facility hand hygiene strategy. Because we know that patient hand hygiene prompting can be effective at improving healthcare worker compliance. In the few studies that have been done that looked directly at patients performing their own hand hygiene. We know that patients kind of setting the example is effective at improving compliance among healthcare workers. And so we want to be thinking about these other components of our overall infection prevention strategy or bundle, including patient and family education, and how might that be tailored to a patient hand hygiene protocol. We want to be thinking about how we're monitoring and providing feedback on hand hygiene compliance, not just to healthcare workers, but also to patients and their families, and think about how are we encouraging, what kind of feedback are we providing to patients about hand hygiene that they're supposed to be providing. We know that organizational culture and an organizational commitment is critical to sustained hand hygiene changes, and that we need to look at how we can facilitate organizational leadership and management buy-in as part of an overall infection prevention and hand hygiene strategy. We need to be thinking as part of this multimodal strategy about our product placement, in particular point of care, location of these delivery devices and of these products, so that at the very least that these products are accessible to patients and their families, and that they can use them kind of if they're so inclined. So some of the considerations for a patient hand hygiene program are developing recommendations for the timing of this protocol, when patients should be performing hand hygiene, what technique, how are we going to recommend that patients perform hand hygiene, what are the product formulations that are most effective and that are most have the highest acceptance rate by patients and families, given their different usage characteristics compared to healthcare workers. How do we locate these dispensers and these products? Are point of care or personal carriage solutions really ideal for patients? But the critical thing here is to think about integrating our approach to patient hand hygiene as part of this bundled or multimodal approach, and looking at how we use it to engage patients, how we educate patients, how we use it to provide feedback to staff and patients, and that really is important. So the objective for today, hopefully you feel like we've addressed the current evidence for the role of patients' hands in the transmission of these pathogens and infection, some of the current efforts that have been done to include patients in hand hygiene, and that there were a bunch of important considerations in implementing a patient hand hygiene program, and that hopefully as you think about your facility, your institution, and the opportunities that patients have to be involved in hand hygiene, to perform hand hygiene as a patient or when they come to visit someone that they care about, how what strategies we need to be thinking about really making the most effective program possible. So I'd love to hear back from you, either about things that are working or not working in your facilities, and any questions or comments that you had. So Jennifer, I'll pass it over to you.
Okay. Let's go ahead. I'm going to call out to the operator, Alicia, and have her give instructions to the participants. If they want to call in with their questions, they can, or they can post them on the online chat box. Great. And while we're doing that, we'll have probably about 5 or 7 minutes to do the questions and answers, and we can stay on the line a little bit longer than that, but I know people will need to be dropping off for other engagements that they have. As you do, Tim, I'm going to have you go ahead and move over a slide so I can just introduce a couple of things to them before they go. And here's just some contact information for Timothy and for myself and other Quality Improvement Organization contacts. And if we move on to the next slide, it just shows you a couple of upcoming webinars in our series in July. We will have the CDC with us. We originally had the topic of summer bugs, but we've evolved it into something about spotting and relaying epitrends to providers. using some CDC tools. It's going to be very, very good. We may be adjusting the date in August for preventing central line infections because we're lining up a speaker who could address some late-breaking things on CLABSI. And so let me just go to Alicia and see if there's been any questions come up on the phone line.
No, ma'am. There are no questions in queue.
Okay. And just know, too, that folks, that as you close out today, and we're not closing out right this second, but if you need to, you will see a SurveyMonkey jump up on your screen, and it only takes about a minute. Make sure when you're answering, if you happen to be doing the strongly agree or strongly disagree, make sure you know which end of the spectrum you're on, because sometimes folks are accidentally putting one or the other. We do have a comment on the chat box right now that says, we have found bundle strategies the most effective method for creating a standardized approach based on evidence-based data to create awareness, engage staff, patients, visitors, and to educate and reevaluate progress. So that those bundle strategies. And Kathy McDonald has asked us to back up, Tim, to the contact information. I wanted to, Alicia, do we have any calls on the line right now?
Can you hear me?
I can hear you fine, yeah.
Okay, all right. So this is Barb Boland. I'm from St. Joe Regional Medical Center in Lewiston, Idaho, and I have a combination of a comment and a question, and that is that a while ago we adopted the WHO organization, Joint Commission, everybody, and then we have the posters everywhere. We adopted the buttons. We came up with a hand signal, to remind people. We encourage the culture to, that I have the right to ask you, and we've asked, we put it in the brochures that the patients get. So we've really embraced all of that. And of course, over a year's time, a year and a half, we, by direct observation, what we did is we reported everything out. And of course, now we're at 100% compliance. So then we also adopted, part of the hand hygiene solution formula that is adopted by several different states. State of Washington uses it. They actually report it on a website, and so you can go on and you can see, how the hospital is doing in their performance and their hand hygiene. And so I've incorporated that. So what I was hoping to do was when we have, you say you're 100% compliant, but by the solution methodology, which I know is not the best methodology, but by the solution methodology, you're only meeting, 67%. So obviously something isn't going on here. Now we've also incorporated the secret shopper. So we have a subcommittee. They're very proactive, and, even they were like, you're really right. We're not where we were hoping that we would be. And so I thought I had read this quite some time ago, but that the Joint Commission, and I hate to say that it always has to be dependent on them implementing the standard, but I've always wondered, why don't we incorporate it as part of the intake, that it has to be part of the education that needs to be provided to patients right at the very beginning when they're admitted to the facility. And not only does it need to be given, but also that the documentation needs to be there to support it. And I thought that was coming, but I've never actually seen it mandated to that extent.
Yeah, and so, I think we all recognize that the Joint Commission doesn't implement anything, that they develop standards for accredited institutions.
Correct.
And that, you're free to follow them or not follow them, but, of course, most of us prefer to comply.
Report card if you don't.
That's correct. Right. So this is actually encouraging for me, and it relates a little bit to one of the questions I think that Jean Wilson had in chat. And so as infection preventionists, there are solutions and strategies for monitoring and providing and encouraging hand hygiene. But what is going to work think of it as a toolbox, but that one tool isn't going to work in every situation, and that our job as infection preventionists is to really look at the toolbox and say, given this institution, this organization at this point in time with our most pressing needs, that these are the most critical strategies. So I totally agree that, we need to be moving towards not the practice standard, the accreditation standard, we need to make patient hand hygiene part of what we do in healthcare practice, in nursing practice, and in the practice of medicine and promoting it among patients. And we also need to be looking at ways that we can provide feedback. And that could be one of the standardized methodologies that you mentioned. It could be the use of technology. And I guess I would just say that as we look for fits-all solutions, that the slippery slope is that something that's going to work in Maryland might not work in Idaho, and that we need to be held to what the standard of care is, but we also need the flexibility to meet kind of the unique situation of our own practice environment and organizational culture.
I was just curious to see if, I imagine that most hospitals have observing staff of all levels in their hand hygiene at some amount of time each month and then reporting those stats. Does anyone include patients and visitors in that, in those observations and report on that?
Yes. So, maybe people could just post up in the chat if you're doing it. The problem is, from a practical perspective, is that most of the situations when we would want patients to do hand hygiene are by nature very private moments. So, after someone toilets before they eat, let's say, as they're taking medication or having, getting an injection or another invasive procedure. These are really hard moments to directly observe.
I thought with visitors even, I think when this came up in our organization, we're trying to figure out, how to observe it and to include it so we would know if, is our teaching being effective.
Right.
And certainly there are situations where we don't see the patient all the time for a lot of those private moments, but, as visitors come in and out of the room, so we can certainly observe that to some capacity, but just sort of didn't know what other folks might be doing with that.
So, be interested in any comments that you guys had about kind of the compliance or monitoring of patient and visitor hand hygiene, any approaches you had for that. I mean, I think there's tremendous opportunity in the technological advances and in usage monitoring that could happen if, we know certain dispensers are likely to be used exclusively by patients or families, that's it needs to be part of this overall strategy, but it's actually a really good point. It doesn't sound like anybody else has any great solutions, but I think that usage characterization, usage monitoring could be really important in supplementing what it is that you're doing, even if you're not doing secret shopper monitoring.
And Janet and Martha at St. Alphonsus said that they've measured the use of hand wipes on patient meal trays before, but and then another person saying monitoring hand hygiene unit-based champions, infection control observation of secret shoppers. But part of this is that probably a lot of people don't have a program in place yet, really, that's fully engaged with patients in their own hand hygiene. And that's why I so much appreciate this presentation today, because I don't think that we often think of that, but if we're all moving into this patient-centeredness more and more so all the time in a real and genuine and true way. And, having a hand hygiene protocol that fits the patient population and is a great way to pull in that not often thought of member of the care team, the patient, and so their hands have to have regular hand hygiene too. So I really like this. One question that I had, as we're going through questions, is you referenced the protocol and sort of the bundle, the protocol. Is there, at this point in the work that you've done with folks in this area, a toolkit available, or just something like that sort of pulls all this together that people could take away?
We don't yet have kind of a toolkit for patient-centered hand hygiene, in terms of the best products or timing or technique. But I think that's something that maybe next year at APIC we'll have some, leads on the beginning of something like that.
Yeah. This is new stuff. I mean, so probably the best thing that they can turn to is some of the work that you've put into the supplement last month, May 2012.
Yeah, I think that's a good start, but then also their own expertise and understanding of patient hand hygiene. Yeah, the great questions. I appreciate all the info.
I just typed it in.
Yes. Luann had asked if folks could share what they're doing in this area. Somehow, within this forum, all these people might have some things that they're doing or some ideas that they have, and some have shared it on the chat. And so, Luann, when I send out the recording, and I know Tim has some additional resources he wants me to send out as materials for you guys, I think I'll put a little plug in for if folks are willing to share, if they have something special that they think they could share, if they could share that back, and we could share it with the whole group.
That'd be wonderful. Thank you.
That's great.
Thanks, Luann.
Super.
Well, I want to be respectful of people's time. It's right now, Mountain Time, it's 2:06, and I don't see other questions right now. Super comments on the chat. We saved the chat, and you can too where you are. And again, just as a reminder, as you log off today, you'll get a SurveyMonkey. Give us your feedback on how this is delivered to you and if it's valuable to you, if there's things that we could do to make it better. Alicia, did we have any other callers on the line?
No, ma'am. There are no more questions in queue.
You are always welcome to send questions to me, Jennifer Pelagi. Tim has also thoughtfully left his email address right there on the contact information and is super excited about this topic, so I'm sure would love to have your questions and comments. And Tim, I want to thank you so much for joining us today. It's so exciting to see another piece of hand hygiene that we're not often thinking about, and that this is really some cutting edge stuff that's being pushed out into the literature and into where we're working.
Yeah, it's very exciting stuff, and I appreciate all of the attention, great comments, and participation. So thank you all.
All right. Well, we will go ahead and sign off, and I will send more materials and the recording out to all of you when it becomes available soon. Okay?